Okay, good evening, ladies and gentlemen. Good evening. Thanks very much for coming to this 52nd Maudsley debate here at the Institute of Psychiatry, Psychology and Neuroscience, which is part of King's College London. My name's James McCabe, and I'm the director of the Maudsley debates. I'd like to welcome all of our speakers and thank them for joining us, and our chair. We'll introduce them later on. To start with, we're going to start with a pre-debate vote so that we can get the measure of the audience. So the motion before the House is this House believes that the long-term use of psychiatric medicines is causing more harm than good. Now you might feel, perhaps some people, perhaps most people would feel that in some cases this might be true, perhaps in particular individuals or with particular conditions or particular drugs, and in some other cases it might not be true. But unfortunately, as Nick Clegg will tell you, there are no votes for intermediate positions, and we're forcing you to come down on one side of the fence or the other. Having said that, we will allow abstentions, certainly for the first vote, in that you haven't actually yet heard the evidence from the panel. So can we have a show of hands then, please, first for people who support the motion that the long-term use of psychiatric medicines is causing more harm than good? And I should also say that well, I can probably guess a majority in favour at the moment in the pre-debate debate phase. So while people count those, I just should also say that we have got people also in an overspill room, which is in the Robin Murray Lecture Theatre, because we were oversubscribed tonight. I'm sorry about that. I'm sorry that you don't, unfortunately it's a bit like voting Green. You can vote as much as you like, but people can't, your vote's not going to be counted, so I'm sorry you're disenfranchised in the other room. But while the votes are being counted, I'll just tell you a little bit about the Maudsley debates. They've been going for the last 15 years. They were started by Sir Robin Murray, who's sitting in the corner there. We have about 2 or 3 debates per year, and they're on any topic that's relevant to mental health. And they are, like the NHS, free and available to everyone, so anyone is welcome to come to them. We've had a problem recently in that they've become too popular, and we've had to start, we used to have just an open door policy where we used to just open the doors and let people come. Unfortunately, we then had to start turning people away because we didn't have enough capacity. So we've now changed to a new system whereby people have to register in advance for the debate, and that system in itself is also I'm now having to apologise for, because the tickets all sold out in about 2 days flat, and so most people, well, a lot of people have complained that they haven't been able to get tickets for today. So I'm sorry if you haven't been able to get here today. If you haven't, we have a new innovation tonight which hopefully helps to alleviate that problem, in that we are able to through the magic of science, live stream the debate today. It's being live streamed on YouTube. There's a URL on there, but actually it occurs to me there's no point in me reading it out, because if you can actually hear me, then you must have logged into it. But anyway, you can watch that there, and hopefully, assuming that this works, all future debates will also be live streamed for those who aren't able to make it to the live event. Also, for reasons which I'm not entirely clear about, if you start to get bored of the debate, there is also an option to look at, to have a tour of the International Space Station toilet, and various other options down on the right. So I'm sure the debate will be more interesting than that. Later on this week or early next week, we will post the debate podcast on the website, as we always do. You can find that by Googling Maudsley Debates. And we've got podcasts, audio and video podcasts, going right back to the year 2001, which was when we had the third debate. You can also follow us on Facebook. Again, if you just go to Facebook and search for Maudsley Debates, you'll find our page there and you can join up and be notified of future debates. And the same thing goes for Twitter. So we've got our Twitter account at Maudsley Debates, where if you follow it, you'll be notified. And also we are encouraging people tonight to use the hashtag Maudsley Debates. So if you, debates in the plural, that is, and if you're listening live by live streaming, or if you're in the Robin Murray Lecture Theatre and you want to put comments or questions to the panel, then please do so using that. We can't guarantee to read all of them out, but we'll try and read some of them out. And also people will hopefully provide their own commentary as we go through. There's also been a BMJ article, as there always is for every debate, accompanying the debate. It was last Saturday, where the four speakers presented their pieces. I also have to give you a tell you about the fire exits, which is if you hear a fire alarm, then you should look for a green fire exit, and outside there will be marshals who will guide you to safety. If you want to contact me about debates, if you've got an idea for a debate or a complaint or anything else you'd like to speak to me about, james.mccabe@kcl.ac.uk. I'd like to thank James Davies, who contacted us originally with the idea for this debate. As always, Simon Wesley, who is a long-time supporter of the debates and has facilitated this particular debate. And also Nikki Whitelock, who's our events coordinator, who has done all of the hard work and administration organising the debate, and also her team of volunteers who are helping by counting and by holding microphones on booms. Sorry, I'm now suddenly aware that I haven't asked you the noes to vote. So, if you're against the motion, can you raise your hands now, please? Okay, so that shouldn't take as long to count. Normally at this stage I also tell you about forthcoming debates that we have coming. I'm not going to do that this time because the last several times I've done that we've ended up changing our minds and changing the debate. But that's partly because we do try to make our debates topical. So they're often in response to events that have happened. For example, when the Health and Social Care Bill came in, we then very shortly after that did a debate about the role of privatisation in the mental health sector and in the NHS generally. Okay, have we got that? Can we have any abstentions, please? Okay, anyone who's been to any of these debates before will also know that I'm not very good at putting the debates on the slide at the end, and often the graph comes out looking a bit meaningless, but let's try it. So 4... Okay, so before the debate, the scores are: we have 126 people supporting the motion, 64 opposing the motion, and 28 abstentions. So I'll leave that up there while the debate goes on. So it just now falls for me to introduce our chairperson, which is Till Wykes. Till is the Dean of Psychology and Systems Sciences here at the Institute of Psychiatry, Psychology and Neuroscience. She's also a Professor of Clinical Psychology and Rehabilitation. Till is known mainly for her work in, or recently mainly for her work in the treatment, the psychological treatment of psychotic disorders, particularly cognitive remediation therapy. And she's also well known as a champion of mental health service users and in championing their involvement in research. So I'll hand over to you now, Till. Thanks very much for coming, everyone. I hope you enjoyed the debate.
Okay, well, just to give you a little flavour of this debate, we're going to have a clean and fair debate, which means that everybody gets exactly the same amount of time. And they're only going to speak for a very short time, so each speaker gets 5 minutes each. And the reason for that is we really want to have some interaction with the audience. That's what a debate is about. Then at the very end, we'll have another 2 minutes from one speaker from either side, and then we'll have the vote again. So that's how the whole thing will go. And it will be clean and fair on all sides, and there's a lot to play for. At least 45 votes, I think, wasn't it? And the abstentions at least. But we hope some people will actually think of this treat it in a fair and open-minded way, and on the basis of the arguments that are put forward to you this evening, rather than on your general beliefs, I think, about it, because that's what a debate is about. It's about how good the arguments are that you consider in the room today. Okay, so I'm going to start straight away because we want to have as much time as possible for each speaker. Each speaker is going to have, as I said, 5 minutes, but I have two helpers in the front row, Louise Pratt from the Institute and Ed Sykes from the Science Media Centre, who are going to help with the timing, so we definitely don't go wrong. So for each speaker, there'll be a wave from Ed when it gets to a minute before the end of your time, and I will tell you when it's all over. And when it's all over, I'm pretty fierce, it is really all over. That is the red card. Okay? So, if you could start now. So we're going to have the first speaker, 4.
So, this debate is about weighing up benefits and harms of long-term treatment of psychiatric drugs. It is tempting in such debates to entertain, use anecdote and rhetoric to win your side. I won't do that. I'm a scientist. I work at the Nordic Cochrane Center, and in Cochrane we rely on facts. So I'll give you some facts. Cochrane reviews have shown that psychiatric drugs are generally pretty ineffective. People think they're effective, and that is because the spontaneous improvement is mistaken for a drug effect. It's also because the randomized trials are pretty biased. Most of the trials are done this way. You have patients who are already in treatment with the drug, then you have a short washout period, then you randomize to placebo or a similar drug. That means that you introduce withdrawal symptoms in the placebo group, abstinence symptoms, a cold turkey. And that cold turkey can create depression, psychosis, and so on, which is then misinterpreted as a return of the disease. So that's a major reason why most of these trials are badly flawed. Another reason why they are flawed is that they are not adequately blinded. These drugs have conspicuous side effects. So there are studies that have shown that in most cases, doctors and patients know who is getting active drug and who is getting placebo. So there is a very important Cochrane review that in depression that only looked at trials that had something in the placebo, namely atropine, because it gives you similar side effects as the tricyclic antidepressants. And that review found an effect of only 1 on the Hamilton scale. That's nothing, because the least difference that people can perceive is 5 to 6. So 1 equals nothing. So if you put something in the placebo so that you blind your trials, you don't see an effect. Now, the trials are also short-term. We need long-term trials. There are not many of these. And I should say that the cold turkey design has actually driven some patients into suicide. Patients with schizophrenia, they committed suicide because of akathisia when they got abstinence symptoms. Now, trials in schizophrenia are also disappointing. Newer submissions to the FDA for new drugs found an effect of only 6 on the positive and negative syndrome scale. And the least clinically relevant difference is 15. So what was found was much less than what is clinically relevant. And you should remember that most of these trials were deeply flawed by cold turkey problems and inadequate blinding, which benefit the active drugs. So the real effect is even less than this. Now, the benefits of ADHD drugs is also uncertain. Whether there is a short-term effect, that is possible, but they also suffer from cold turkey and unblinding bias effects. Moreover, almost all of these trials carefully selected responders. So they randomized only people who responded to these drugs. This is a deeply flawed design. They call it an enriched design. I call it a design that makes the drug companies rich. And if there is a short-term effect on ADHD, it surely is replaced by long-term harm. There are very few long-term trials, and those that they indicate long-term harm. And animal studies clearly show that these drugs likely give permanent brain damage. This is likely the case, or at least long-term brain damage. This is likely the case for all psychotropic drugs if you use them more than a few weeks. So these drugs are incredibly harmful, and I have estimated that in people older than 65, they kill around 500,000 people annually in the USA and in Europe. Only benzodiazepines, antipsychotics, and antidepressants. They kill very, very many people. There are no beneficial effects that can justify this tremendous harm on people. So I have estimated we could get away with using only 2% of the drugs we use now, mostly for acute situations, with a firm plan for tapering off as quickly as possible. So we need new guidelines to reflect this, and we need withdrawal clinics all over the country, because very few doctors know how to withdraw patients from psychiatric drugs. That's it.
Shall I start, Phil? Okay. Thanks. Well, obviously we're batting against the poll here, but as polls can be wrong. So I will specifically rebut my opponent's points in the last 2 minutes that I have, but I'll set out some preamble that's important in the first thing is that psychiatric conditions are common, complex, and costly. They're over 1/5 of healthcare problems. A huge area. To selectively choose one small part and generalize is almost certainly going to be wrong for therapy and for other things. It's also true to say that these are important. On average, although this is an average, people with severe psychiatric disorder lose 10 to 15 years of life. That's true in schizophrenia disorders and personality disorders. So there are illnesses and they need to be treated. All interventions, whether it's pharmacology or surgery or psychotherapy, are a balance between benefits and harms, and that should be evaluated in the round for everything. And that's true for these drugs as for much as anything else. To take all part of the evidence, criticize, generalize it to everything is simply wrong and indeed unhelpful, and potentially might cause people to lose their lives. So if we look at the evidence in the round, has been done by my colleague Stefan Leuk, there's no psychiatric drugs are on average as beneficial as common medical interventions, things like antihypertension. Nevertheless, there are some very trenchant critics who oppose the use of these drugs. Now, based on an evidence-based approach, that's a very good thing. Now, we've already heard the Cochrane quoted, an author myself, and indeed Cochrane has weighed into this debate, and I will go over that later. But if we look at the evidence, not just randomized controlled trials, there's regulatory agencies, marketing surveillance. These cause drugs to be withdrawn. We've had drugs, psychiatric drugs, withdrawn from the market in the past 10 years, which were perceived not to do or to do harms. The notion that we should simply follow the rule of getting rid of 98% of them is a grotesquely bizarre argument, which will actually damage many. So let's go into some of the detail about the overinflated concerns. Now, it's true that most trials are 8, 12, or a few weeks, but there are a few long-term studies which have looked at lithium, something we haven't heard mentioned so far. Hospital and institution, this was called a toxic placebo in the 1950s and 60s. That's been shown to be, it's been shown to be efficacious, and the side effects, although still present and significant to some extent, are far less than previously thought. It also reduces suicide rates, and that's very important. Suicide is a pretty hard outcome, and if we can make an impact in that, it's important. So drugs like clozapine, there was a fear that drugs like clozapine and antipsychotic resistant schizophrenia would actually make outcomes worse because of side effects such as weight gain and cardiovascular disease. This was examined in the whole of Finland by Professor Tiainen, who found that life expectancy went up in the years after the reduction of clozapine, and this was specifically associated with clozapine reducing suicide rates. So, I mean, these are important data, long-term and national data, shouldn't be ignored. Lastly, in terms of mood disorder, Professor Angst, my colleague from Zurich, with respect to people here, he's the most senior academic psychiatrist in Europe at the moment, looked people up since 1949 and looked at the effects of treatment. The people that remain in treatment, pharmacological treatment, are more than those that don't, and yet their long-term outcomes are better, including a reduced suicide rate. That's evidence that's publicly available, and of course is not an opponent. So in summary, psychiatric drugs are of course a benefit of positives and negatives, but the evidence such as it is, and the evidence is persuasive, supports long-term use. Thank you.
The next person is Sami Timimi, and the last of our medical peak tonight.
Okay, firstly, I'd like to make two important points. One, if you are taking psychiatric medication and agree with this motion, please don't stop taking your medication abruptly, because this can be very dangerous, and please seek further advice. Two, psychiatric drugs do help many, particularly in the short term. For example, someone tormented by voices may experience relief from the sedative and emotional blunting effects that some of the psychiatric drugs. But this motion is about long-term effects of medication, and specifically whether the benefits outweigh the harms. And here we have to turn to the evidence. Evidence leaves little room for doubt. We have plenty of evidence that they can cause harms, sometimes immense harms, physical, psychological, and social. They can cause dependency, they can cause withdrawal problems, and we have very little evidence of lasting benefits that justifies exposing people to these harms. And I'll give you two examples of this. First, long-term use of narcotics. This is associated with serious risk of cardiovascular, metabolic, and neurological side effects. Is it worth exposing people to this level of harm? Many findings cast doubt. For example, the largest follow-up study diagnosed with schizophrenia, who were followed up for 5 years, was the World Health Organization study. And that one found that the best outcomes were in developing countries. About 15% of the patients had exposure to antipsychotics, compared to the developed countries where about 90% exposure to antipsychotics. At 5 years, 64% patients in the poor countries were asymptomatic, compared to only 18% in the rich countries. study of long-term outcomes of patients with psychosis found that those who came off antipsychotics had much better functioning, fewer symptoms, and were about 8 times more likely to be classified as. And recently, Wunderlich and colleagues published the first randomized controlled trial of maintenance antipsychotics for people. And at follow-up at 7 years, they found that the withdrawal had much better functioning and twice the recovery. Now, if someone can show me well-conducted and impartial studies that demonstrate superior functional outcomes for those who stay on long-term antipsychotics, then I'd like to see them. And if you can't, then surely it is unethical that we continue to expose numbers of people to long-term antipsychotic treatment. Indeed, one Cochrane review recently, the first episode of schizophrenia, has cast doubt on whether antipsychotics are effective even in the short term. In my field, I'm a psychiatrist. The most widely prescribed drugs are stimulants. They show a very similar. Harms from stimulants include cardiovascular, growth, and psychiatric, and they're usually prescribed for many years, despite the long-term that are available show that regardless of initial severity, children who are diagnosed with ADHD who don't take stimulants have outcomes that are no worse and in many cases much better, particularly in terms of functioning and symptoms, than children with stimulants. So this picture, some short-term benefits but little evidence of long-term benefits, is typical of what you find when you examine the evidence base. We are in danger of creating morbidity on a massive scale with our evidence-based use of long-term psychiatric medication, which seems to be increasing in volume. Official guidelines like NICE seem to have plenty to say about starting people on these medications, but have given advice on long-term treatment and how long to give these medications and how to help people safely withdraw. It seems that the widespread use of psychiatric medications these days is the result of good marketing and not good science. Psychiatry is full of people like Professor Young who have swelled their pockets and made their careers through the corrupting influence of the pharmaceutical companies. And it would be interesting to see whether Professor Young conflicts of interest tonight. So the evidence is clear, and the big question is not whether long-term prescription does more harm than good. The question is, what are we going to do about it? Bodies like the Royal College of Psychiatrists have, I believe, scientific and moral duty to do something. And if they won't, we are, as psychiatrists, in danger of becoming part of other than what we should be, which are strong advocates for patients and those who serve them.
Okay, I just wanted to remind people that we are debating a motion rather than debating the idea of something needs to happen. So we're actually debating the single motion that's up now, which is about psychiatric drugs doing more harm than good. There may be other things that everybody may want to happen following that decision, but we need to argue. I wanted to remind everybody that it's about the motion and not about anything about actions afterwards. Okay, I wanted to introduce the non-medical person now. So this is John Grayson. He's a feature writer for The Guardian.
Thank you very much. First, the disclaimer. I'm no big fan of all the medication I take is generic. But I am a person with mental health issues, and I think for the patient to be left out of the debate is, to me that is insane. I've suffered from depression and anxiety 20 years, and I've been treated in ways. Could I have done more to make my life easier? Well, I could have a less stressful life. Being a sketch writer isn't always easy. I could also be a Spurs season ticket holder. Though perhaps the team chooses you. That could be another debate. But so my response much as a patient. If the proposal is basically psychiatry, it appears to me that psychiatry is absolutely nowhere in its entire history. If all that's being said is that we should try and prescribe less drugs and get off them as soon as possible, that's a bit like saying stop taking ibuprofen and you've got to finish, when your headache's gone. The thing is that it really isn't that binary. And kind of time and experience I've been on fluoxetine and off fluoxetine, and I discovered that it's actually best to stay on it for a period, and if when a depressive episode recurs, then to increase temporarily. That's what it is, trial and error. The thing is that, we may be mental, but we're not stupid. We actually do know. We know what the risks are. We know there are side effects. The psychiatrist was very clear that fluoxetine may not work in my case or whatever. But because we're desperate, we've tried absolutely everything else. Now it's possible that proposal is absolutely right, and that fluoxetine has had no effect on me whatsoever, and that my recovery periods have been entirely coincidental. That is a possibility. I haven't done a trial. I personally don't, but it's not something I want to sort of look at. I've also tried all therapies. I don't believe there is a single childhood trauma that would throw any light on my life. I treat now as kind of emotional dialysis to sort of help me get through. I've even had CBT, which is often the preferred treatment in a psychiatric institute, and the CBT happened to be the most anxious person I've ever met. Her line was always, being late makes me feel anxious, but she was always late. And I was also, when I was in residential care, always given a scorecard to score my level of depression. And it stayed resolutely the same, because they would ask questions. Have you felt like committing today? And I have to say that this is a question that I ask myself every single day. It may be a sign of unwellness. It's not something I act on, but it's a fundamental part of my existential being. If you're alive, I can't believe why you would not ask yourself. So my scoreline stayed exactly the same as if I was terminally depressed, but it turned out that I was actually getting, so something was actually working. It is imperfect, and surely it should be up to the patient to choose. Life isn't always that easy. But thanks to my shrink and therapists, we've kind of managed it. I've got evidence that I will have other depressive episodes in the future, and I'm lucky to have a family and a workplace where health is not taboo. I think it would just be great to make medication a taboo as well. Thank you.
Okay, well, thanks to all the speakers. I do want to, we're going to open the questions to the floor. When you, before you speak, can you make sure you have a microphone in front of you? It's very important because we're actually recording this and live streaming, and nobody in the Robin Murray Lecture Theatre on YouTube will be able to hear you unless you've got a microphone in front of you. I'm probably going to take 2 or 3 questions together and then allow the panel to answer. We do want to keep this a clean fight, so I think the issues about, who's made money out of it, we have to be very careful about, casting aspersions particularly on the speakers. So I think that's an important issue we've got to consider. We want to get in as many people as possible. This is a public debate. and we want to get as many members of the public involved. So we need a question from you, and it needs to be a short question so that we get a chance to include many more. And I'm warning the speakers as well, because their answers need to be brief in order to be able to get more people involved. So I believe this person was the first person, just up here on the right.
Hi, my name is Cheryl Prax from Speak Out Against Psychiatry, and I'd like to say to John, is it Crace or Grace? Crace. I would like to say it's okay for you, but what about the people that are forced to take the drugs against their will, held down, injected in the hospital, at home? They don't have any choice. And my friend Jean Cousins, she killed herself because she was on a CTO and forced to take these drugs that she knew was damaging her brain. And I'd just also like to mention electroshock while I'm here, because we have a demonstration at the Houses of Parliament, 2 o'clock on Saturday, if anyone wants to come.
Okay, next question. We're going to collect a few. So there's Jonathan over there, then you, and then we'll have an answer for and then I'll come towards the back. If you would, actually, if you'd like to say your name and say, as the first speaker did so eloquently, I'm just reminding other people that if they'd like to, I think they should say their name and the organisation if they wish to, that they might be representing.
Thank you. So I'm Jonathan Beineman. I'm a clinical psychiatrist, so I do get paid for prescribing. I don't know if that's a conflict of interest. And I also get paid for stopping medication. I think what I'd like to say is I spent the first 10 years or so as a psychiatrist doing what I think a lot of us do, which is to tell people how things like antidepressants are supposed to work. And in the last few years, I've started listening to people telling me how the antidepressants work, and it's been a very different story. And in effect, what I experience in the clinic is a long series of N=1 crossover trials. The individual tries the medication, they experience it, they stop it, they experience that, they start it again. And what I've learned, I think, is that I think John Crace's approach illustrates the right one, which is that you find out by trial and error what works for you. However, I see far too many people in the clinic who are taking medication, often for many years, because of the belief of their doctor that the medication must work, in the face of very clear views from the patient, very clear experience from the patient that it doesn't work. And I think that we all need to be much more open to actually listening to people's individual experiences of the medication, which are highly variable. I've learned a lot about withdrawal effects.
Okay, Jonathan,
and a lot
so
about
is
how
there
they
a
work.
question?
So, what do you think of the N=1 crossover trial, given that the large-scale randomized trials seem to have such unhelpful evidence or lack of it for the clinical psychiatrist?
Okay, I'm going to take one more question and then come to the panel. Just here. Just sorry.
Thank you. Dr. Bob Bohansky. I'm Chief of Clinical Services at Southwest Behavioral, the largest behavioral health provider in the southwest part of the United States. I was encouraged to hear that you only have a 10 to 15-year life decrease on your psychotropics. In the States, where we have 5% of the world's population, we consume 80% of the world's psychotropics. And our life expectancy has decreased by 25 to 35 years, perhaps one of the side effects of long-term use of medication. But the question I have is, we've really come to a point in our practice where integrated care is our new buzzword, where we've discovered the neck, or rediscovered it, and said we have to get rid of the Cartesian dualism and start treating the body wholly. And perhaps by treating the body wholly, by the integration of primary care into our behavioral health practice, we are learning those things which help provide for wellness instead of constantly chasing illness.
And your question is? Are
you looking at a similar approach here, or are you going to stick with the illness model?
Okay, well done. Okay, now Okay, John, I think the first question was aimed at you.
The first... Actually, no, sorry, Dave. The first question was for me. No, well, obviously, I am not in favour of people being held down again and being forced drugs against their will. I mean, but that is a kind of extreme. And...
Okay, folks, let's just let John finish, please.
The question up for debate was, should we ban all psychiatric drugs on the basis of the result? And I'd be willing to bet that there are a lot of people in this room and around the world who have benefited from them. And maybe you want to think about how they are administered, but to just sort of ban the drugs willy-nilly just seems absurd to me.
Okay, so let's have the answers to those questions first. So, Sami.
Can I just try and bring the debate back to the question of evidence? Because this isn't a debate about banning all psychiatric drugs. It's a debate about whether long-term use of psychiatric drugs is associated with more harms than benefits. And I think we have to be very careful about getting into anecdotes. This is where I think, as a clinician, the trial of n equals 1 is what I do all the time as a clinician. But when we're trying to evaluate this question, we need to return to the evidence. In terms of patient views, actually, if you look at the literature, there are plenty of literature which says that I think your experience of medication, and it's great that it's been something that is helpful to you, isn't shared by the majority of people who are on the receiving end of psychiatric medication. So I think we have to be careful about confusing anecdote and stories and personal stories with the evidence. And if we stay at the level of the evidence base, that's what we're trying to figure out in our debate today.
Okay, so we've got two questions about integrated care and about n equals 1 methodology. So maybe if we do it in order, Allan and then Peter.
I think every prescribing doctor does an N-of-1 trial all the time. I spend much more of my time taking people off medication, as you very well know, Jonathan, than I do. I think one of the problems with medication is that we don't have continuity of care, so people see different doctors all the time. And if you actually are using medication, it behoves you to use it carefully, and our healthcare system at the moment mitigates against that. In terms of integrated care, I'm tempted to say that the reason the outcomes are worse in the United States is because you don't have the NHS. And the NHS is an integrated healthcare model. And the 10 to 15 years of life lost is not due to drugs, it's due to the illnesses.
Okay, so Peter Gøtzsche. Okay, so let's go on to another reply.
Yes, the N of 1 to cross over in one patient is a very bad idea in psychiatry, because when you stop the drug and get abstinence symptoms, you think that your disease has come back, and then you get back on the drug. Yeah, the psychiatrists and other doctors are pretty poor at distinguishing between whether it's a withdrawal depression or whether it's a real depression. So that's not a good design. On the other hand, it's very good to listen to the patients. I have a lot of patient views in the book I published in September with a funny title, Deadly Psychiatry and Organized Denial. And these patient views clearly, consistently tell us that the patients don't like the drugs. Not even in randomized trials where the psychiatrists think that the effect is great. And then when you ask the patients in the same trial, they say they don't work. And equally many leave the trials before the trial is over on antidepressants as on placebo, which tells you everything, that on average, considering benefits and harms together, which is what this meeting is about, the patients think they don't work for depression because they leave the trials equally often on active drug as on placebo.
Okay, so I've got a question from the Robin Murray Lecture Theatre, and there's one right at the back that I promised before, and one in the middle here, and one over there. I've got you all, but I'll do it 3 by 3. Okay.
Hi there, Samir Johar. I'm a consultant psychiatrist here for people with first episode psychosis and a researcher. And my question is, to the two gentlemen speaking for the motion, have you acquainted yourselves fully with the evidence? Because when you stand up there and you use the word science, it's people take what you say on board, and you've been a little bit selective in your reporting. You haven't mentioned relapse prevention, the number needed to treat for relapse prevention with antipsychotics. Number needed to treat is 4. I was also going to ask you, you mentioned the IPSS study of the developing world. The converse was found when people looked at follow-up data. And Wunderink found a separate finding when he looked at the 2-year outcome. And the findings are heterogeneous. My question to you, gentlemen, is if you're going to be standing up there and using the term science, surely you have to present it in a balanced fashion.
Okay, thanks for that. There was a questioner over here, and I've now lost her. Yes? And then I'll read you the one from the Robert Murray Lecture Theatre.
Hello. My name's Ursula Reid. I'm a researcher in mental health, but I used to be a care coordinator in SLAM and other places. But so my question really is about that, which is about the psychiatrists prescribe the drugs, but most of the enforcement comes into hands of social workers, OTs, and psychiatric nurses on a day-to-day basis, and this is very damaging to the therapeutic relationship, which has been shown to be one of the major factors that can support recovery. So what can be done about that?
Okay, thanks a lot. And then I'll read you the one from the Robert Murray Lecture Theatre, which is from Dr. Emilios Lemoniatis from the Tavistock and Portman. He's asking, why does the BNF, which is the British National Formulary, which is the book which tells you about prescribing, why does the BNF not give advice on withdrawing medication? So as the first question was to you, maybe one of you two could answer the very first question from the back.
Well, the first thing is I'm not going to respond to an insulting remark that we don't know the science. Actually, I'm sitting. I am sitting next to one of the world's leaders in terms of looking at the science and in terms of involvement with the Cochrane collaboration. What I will respond to is your question about relapse prevention. And this is where the evidence is actually very interesting. If you're talking about relapse prevention in schizophrenia, if that's the thing that you're talking about, but I can also talk about relapse prevention in depression, the study that I quoted from Wunderlink is the first randomized controlled trial where they had one group on maintenance antipsychotics and another group on a withdrawal system. Now, when they looked at the follow-up after 3 years, there were indeed more relapses in the group that were on the withdrawal. But when you looked at the outcomes by 7 years, the relapses had caught up in the group on maintenance, and they were now more. But the thing that had really changed in the withdrawal group is that they were more likely to be recovered, they were functioning better, and what had happened, and this is one of the problems with people on long-term antipsychotics, is more of the people who were in the withdrawal group had regained what you might call citizenship. So they were more likely to be in a job, more likely to be in a relationship, in better housing, and so on and so forth. In terms of depression, the evidence again is very clear that people who get better with psychological approaches as opposed to people who get better on medication arms experience similar effect sizes of change, but if you follow them up longer, they are much less likely to relapse than people who get better through medication. So again, I think the evidence, the science, and I'm not afraid to use that word, and I think I'm using it absolutely appropriately, the science says that medication is not the way to go about getting relapse prevention in the long term. Unless you think that a good outcome is really the effect of sedating people and emotionally numbing them. If you think that's a good outcome, then that's fine.
Okay, we had two more questions, so perhaps Alan, you can...
You wanted me to answer the question of the therapeutic relationship. I think that's crucially important. I think it's underestimated. I think, we have a team approach in psychiatry. Medication is only a small part of that, but everyone should be involved in that. And anything that undermines the therapeutic relationship with the therapist is bad. That must be said, it's not the whole thing. Was there another question you wanted me to ask?
The question was a BNF, and why is
I actually think we're very bad at withdrawing medication. I think it's an area of education that could be done a lot better. And I've studied the withdrawal of antidepressants for years, and other medication. I think that causes a major problem. There's an exacerbation of illness, and it's something that should be avoided. But it's understanding the benefits and harms of the medication, one of which is stopping it too suddenly, and there's ways of doing this much better. But yes, I mean, I think there should be more advice on stopping medication appropriately.
Okay, I just wanted to remind everybody that we are discussing, this House believes that the long-term use of psychiatric medications is causing more harm than good. We're beginning to roam away from that crucial question to interesting ideas. I'm not suggesting they're not, but I think we should actually think very carefully about, when asking a question now, it should be to find out the information you need for deciding how you're going to vote at the end of this debate. So, questions. Ed, there's somebody in the middle, and somebody right at the back. Okay.
Cheers. Hi, I'm Ed Sykes from the Science Media Centre. I've got a question, I think, for Peter. You mentioned the kind of bias selection or way of doing the randomised trials you were talking about, and saying that there's an issue with patients going cold turkey. Did they only go cold turkey in the arms of the trial where people were being given the new tested drugs, or did they also go cold turkey in the other ones where they're being given the placebo or given the existing treatments they're being compared against? And secondly, what would be the best way of doing these trials if you're saying these are flawed?
Okay, not yet, because we're going to collect a couple more, nearly off the mark, but you'll have a bit more time to think about the answer too. So, person in the middle here. So, if you'd like to say your name and where you're from.
Hello. My name is Stuart, and I'm a public member with CCHR, but my question is specifically to John, if I may. I found your story quite interesting. You said that you'd tried almost everything, I think was your phrasing, and I was curious if you could, you mentioned CBT, but I was curious if you could expand a little bit on what all the different things were. You made it sound like you tried like many things, and in particular I'm curious what exploration you did for did you look for a physical medical cause for your condition? Did you do biopsies or anything else, or was it purely on the mental side?
Okay, thank you. We've got one right at the back. So I am keeping my eye out for everybody, but you do have to keep your hand up high. I've seen you already. Don't worry. And I've seen you over there. So I'll remember where they go. I'll just this one and those two first. Next. Okay, thank you. Have you got the microphone?
Yeah, thank you.
Okay.
Good evening, everybody. My name's Andy. I'm a director of a charity called the Consortia of Therapeutic Communities. I just suppose the question really is about the use of language. And now a lot of what has been said tonight kind of reinforces a paradigm, and it reinforces a belief in certain things. And the question really is about, can we challenge our basic assumptions here? And it follows on really from what the gentleman in the lilac t-shirt was saying. I'm sorry, I didn't get your name.
That was
But
Andy,
we all talk as if we're, and I'm not making it, I'm trying to test this out, because I don't kind of use we assuming that people agree with what I'm saying, like the gentleman from The Guardian did. But the question really is something around, are we so invested and identified in the language, in the understanding, in the kind of belief system of psychiatry, that when we actually debate this subject, we talk about the long-term effects of psychiatric medication as if we agree with the worldview within which that sits. And the question that I'm really asking is can we actually kind of challenge those beliefs at a much more fundamental level? Because I think that they arose within a certain time in history, really post-Enlightenment. And actually, as we've moved through time, we're starting to challenge these assumptions now, and it's a question about how we might view this debate in 100 years' time or 200 years' time, when we look back at history and how our views have changed about the nature of human beings and the nature of consciousness.
Okay, thank you. I think I did remind everybody that we're talking about the long-term use of psychiatric medication. Yeah, and we can time travel for 100 years, but I'll first of all offer Peter Gøtzsche the chance to respond to the very first question, and then perhaps John Crace for the next two.
When you take patients who are already in treatment and have a short washout period of about 1 week, typically, some people will get withdrawal symptoms. And those that can then get randomized to placebo, they will still have withdrawal symptoms and they will perhaps feel worse. Whereas those who get randomized to another drug will feel relieved. I'm better now. And also withdrawal symptoms can come later than 1 week. So it's indisputable that this design introduces harm in the placebo group and bias in randomized trials. So what you should do is only to include patients where none of them were in treatment beforehand. And there is a Cochrane review in schizophrenia where many people were first episode schizophrenics, but there were also a mixture with second episode schizophrenics. But this Cochrane review is very important because the authors conclude that they are uncertain about whether antipsychotics actually work for an acute psychosis when you haven't harmed the placebo group.
Okay, can we, I hate to bring people up on their language, but these are people with a diagnosis of schizophrenia because they're not their disorder. So if possible, let's not use the word schizophrenic or epileptic or any of those other words. Thanks.
I'd just like to start with an observation. My daily workplace is the House of Parliament, and honestly, it looks tame compared to this place. This is sort of like a bear pit. I hadn't realised that psychiatry was quite such a vicious institution. But to the specific question on the did I have sort of medical Mostly they were psychotherapeutic. I went through all sorts of different types of therapies, of sort of group therapy, psychoanalysis, all sorts, and they all had sort of varying degree of short-term effect. But one of my conditions, and the one that actually ended me in residential psychiatric hospital, was extreme hypochondria. So I can assure you that I had any number of completely unnecessary medical procedures, so investigating for illnesses that I didn't have. And one of the ones that I ended up in was I'd managed to convince myself that I had BSE, for which the only proper diagnosis is post-mortem. And therefore I could not be kind of talked out of it by having yet another sort of lung scan, or whatever. So when I say that I have, it's sort of partly flippant, but yes, when I say that I investigated everything, I had no idea really what was going on. I just knew that I was going mad, basically, and I don't sort of mean that kind of. I couldn't get out of bed, and my life was falling apart, and periodically it does fall apart again, but it can kind of be pulled back together.
Okay, thanks. I'm going to
Partly, yes.
Yeah. Okay, so we'll stop the conversations and we'll go on to, I'm going to do 3 more questions. They have to be very brief because we want to get on to the 2 minutes, and I'm going to aim for the person in the pink shirt who's been up there for a while, and
Thank you.
You asked the question.
Thank you.
And I'm going over there because we haven't had one over there.
I'm Dr. Bob Johnson. I'm a psychiatrist, consultant psychiatrist. I have a very simple question. In Dr. Joanna Moncrief's book, The Myth of the Chemical Cure, on page 244, she says, all our medications work by intoxication, i.e. they're not much better than medicinal brandy, in which case long-term use of them would cause harm. What do the panel think?
Okay, so the next question was at the front row. Excuse me, it was you? Yeah.
I'll try and be brief. Sorry, hello, I'm John. Firstly, a couple of questions have already been answered, but the declaration one wasn't actually an attack, was it? It was a question. Anyway, you obviously don't want to answer that and just attack back.
Excuse me, can we just ask
John,
the question?
As you said, sir, no disrespect, but when you mentioned your memories, your childhood memories, a lot of things happen to us before our memories start what cause psychosis is. Yeah, this has been proved over the years. And finally, not to get into anything too deep, but open dialogue, obviously you haven't studied. And obviously this country doesn't want to know, so far as I can tell, all the campaigning that's going on, the NHS, whoever people are supposed to be helping people and recovering people, doctors, Hippocratic oath, 70-80% cure rates for 20 years. And they still want to do a pilot. Yeah? Are you joking? People are dying on the street. What do you really think is going to happen when people find out what has been going on? Really? And as this gentleman said, I'd like to finish quickly, sorry.
We have to finish it now.
Please, about the respite houses and the treatment centres and the forced druggings and all this. That's got to be the proper debate, please.
Okay, and then there's one more. No, we're going to have to finish it.
Okay. I didn't understand a word of this.
I'm sorry, I may have done that. Well, I'll come to you if we have 2 minutes, if you've got a very, very short question.
Yeah, Aaron Roberts. I'm a trainee clinical psychologist. Just following on from the point about thinking within a psychiatric paradigm, it's been interesting to note how where the criteria come from for good and bad or harmful. And I guess a lot of that is thinking about the removal of symptoms or distress, which makes sense. And we're often thinking from the perspective of the patient as well, which also makes sense. But I think just to widen it, I was thinking what medication does for many people is quite quickly introduce a change for somebody's sense of self and how they are in the world, relationships, etc. So I was thinking, if we just widen it out, I'm wondering what that means for harm, good or bad, so maybe not just harm, to our culture as well, and what the experience might be like for the people that prescribe. Does it do harm for them, or is it good for them? Just to widen it out a little bit.
Okay, last question from the front. A lot of people have had their hands up, I know, and I have seen them, but I think I did say that you could speak, so that's why I'm handing it on to you. Hang on and wait for the microphone. And this is now the last one.
My name is Sandra Breakspear, and I'm a mother and also a founder of a charity. And I totally agree with Sami and Peter, because my son has been in the system 25 years, and despite all the interventions, he's far worse than he ever was. For the last 15 and a half years, he's been locked in a medium secure unit. 2 psychiatrists have said he's treatment resistant. So can you give me a reply, please, of what can be done if he's treatment resistant, and why are they still treating him? And also, Professor Young, you said about drugs. The drugs do reduce symptoms, yes, but they don't cure anybody. And people may live longer in Finland, but what sort of quality of life have they got from the side effects? And also, do you think it could be because of the open dialogue approach in Finland?
Okay, you've had 3 questions then. So, okay. So we've now got 6.
Before I answer, I think I've got to make a statement about the disclosures of interest. In the written version of this debate in the BMJ, I have full disclosures of interest, and you can see those. None of my colleagues do, as far as I'm aware, and also I'm not selling a book. Treatment resistance is a terrible thing.
Hey, come on. We're not going to have... Come on, we're not having... Could I please warn the audience at least that this is a fair and clean fight? So, okay. Allan.
Yeah, I mean, I understand that lots of people have very strong opinions about lots of things, including lots of you in the room, and you feel that you're justified to be vociferous and even insulting because of your personal experience. But we have to look at things in the round. We have to look at science overall. I mean, Dr. Timimi said I hadn't disclosed my conflict of interest. They're there in the paper. You obviously haven't read the paper, never mind any of the other papers you're quoting.
Okay,
we have
so
to
Allan,
be sensible about this.
Could you answer the question then, Allan?
Which one? I thought I answered the question about disclosures.
No, there are several that have been in the room, so it's...
Well, treatment resistance is a terrible thing, but, you know, we didn't improve outcomes from cancer by, avoiding using cancer drugs, and they have terrible side effects too. We must work towards better treatments for patients. That's one point. What was the other question?
I've now lost it myself, but let's go over here because we need to do the 2 minutes at the end. So
Yeah, in response to the question about whether psychiatric drugs produce abnormal mental states, I think that's pretty obvious now. They work in the same way that any other things that affect your neurochemicals, so they work in similar ways to cocaine or alcohol. Or they all cause abnormal mental states, which can be helpful, certainly in the short term, can be helpful, but let's not get confused. The idea that we've got something that is called an antipsychotic, that it works specifically with a disease process called psychosis, or that we have a disease process called depression and we have something that's an antidepressant, that is the result of good marketing. There is no science to suggest that there is any such thing as an antipsychotic or an antidepressant.
Okay, Allan, and then... no, he's going to speak first. He's just going to answer another
Professor Wykes has reminded me there was a question about the fact that we care for people we don't cure. That's certainly true. There's very few psychiatric disorders for which we have a definitive cure. In fact, many of the problems that are in medicine today we don't have a definitive cure for, but that doesn't mean we shouldn't care for the patient in every way that's practical and evidence-based, and that doesn't mean that we shouldn't work towards better treatments.
It is not correct that Allan Young declared his conflict of interest in the BMJ. He declared none. So I contacted the editors and said, how come this man has not declared his numerous conflicts of interest? So they changed the BMJ paper. I have a version of both PDFs. So it is bluntly dishonest to say he declared his conflicts. He didn't. And my book, I have to mention it because there are 900 references and people accuse me for not giving the 900 references in the BMJ article. I can't do that. So I have to tell you all the evidence is there. And I don't need to declare this as a conflict of interest because everybody knows that an author earns money on his book. That's not a hidden conflict of interest.
Okay, so Peter, you now have 2 minutes. And there won't be any, you won't be told when it's 1 minute. You just have to finish 2 minutes. 2 minutes. Okay, can I just bring you to a bit so that Peter can speak? Hang on a second, Peter. You need to consider, when you're listening, the actual debate motion that we've got in front of us. There's no doubt that there was a lot of agreement amongst the speakers about the need for consideration of new treatments, the need for consideration of when to stop treatments and advice about that, about integrated care, about the therapeutic alliance. All of those things are really important. I'm very glad we discussed them today, but they're not the things you have to make a decision about. The things you have to make a decision about in closing arguments is about, is it more harm than good in terms of long-term use of psychiatric medication? So please bear that in mind when you listen to the closing arguments. Okay, Peter.
First of all, I'm terribly sorry I used the word schizophrenics. I never do this. Patients with a diagnosis of schizophrenia, which on top of that is often. So I only did it because I was pressed at this debate. I agree with you completely. Now, about forced treatment, I'm going to work very hard in this world to put a ban on forced admission to hospital and forced treatment. It kills an enormous amount of patients, although despite that they are begging not to get, they are forced upon them. And according to the United Nations Convention on Handicapped, it should be banned in countries. So I'm going to work on that. The UK this convention, so you need to ban forced treatment by law. You're obliged to do that according to United Nations. Now, about whether these drugs do more harm than good, that is pretty obvious, and we have heard about that lithium reduces suicides. Actually, the Cochrane authors on that report are very careful about not concluding too much based on very few events. and they say that just 1 or 2 negative trials will around the result completely. So whether lithium reduces suicide, but we know that antidepressants kill a % of people who are older than 65. They fall. Many other psychotropic drugs lead to falls. So this is one reason why they kill so incredibly many people. No amount of benefit can make up tremendous harm. That's why we need to focus the next 10 years on people off these horrible drugs. Thank you.
Okay. And finally, we have Allan Young.
So I'm faced with rebutting my opponent's argument. I actually need to do it because in the response to the written argument, there is a rebuttal from 4 coordinators of Cochrane. So 4 people who look at antipsychotics, antidepressants. And this is a matter of public record. So I hope my colleagues go and read the paper, including the letter and all of the disclosures I put in. So the points are that Peter's argument is potentially damaging to patients' well-being and justified within the article. The only data on suicide is his own book. The same is true for total deaths. The data as presented are simply to justify the confident conclusions and the precise estimates reported. This is from 4 authors. This guy's status rests on Cochrane. There's numerous people that disagree with him who are equally, if not more, they conclude that he over findings, his data is substantially out of date. They say, in summary, we are concerned that the picture is a partial one. The extreme recommendations are based on inappropriate interpretation of the data and may harm patients.
Okay. Thank you very much from everybody. Okay. Okay. Excuse me, we're just going to go and vote, and maybe if you behave on either side of me, fierce and so we're now going to have the vote again. So could we have the counters? So could you? Okay, so you know the score. You know that the debate is about, I'll read it. This House believes that the long-term use of psychiatric medications is causing more harm than good. So we want all of those people in favour of the motion. Please show your hands. There are a lot to count, so keep up your hands, please. It will not. We didn't count them in the beginning. As it was described, they're the green vote. When they may be voting what their answer is, and it's not going to impact on this room. Okay, you've got them all. Rest your arms now. All of those people against the Could people please keep their hands up, and we'll have less of the comments, please. You've counted? Yep. So can we have any remaining abstentions, please? Okay. Okay, we're now going to enter the data onto the graph, so it will be you before me, actually, because I can't see behind.
Okay, so the pre was 126 for, 64 against, 28 abstentions. We've swelled our ranks somewhat. After the debate, we now have 136 for, 66 against, and 34 abstentions. So in fact, all three categories have actually increased their vote. Congratulations to all of the speakers, and thank you very much to all the speakers for their contributions, and to the audience, and to Tim for coming. We now have some wine and food upstairs. Also some low-strength lager for the speakers. Thanks very much.